Today's module is on miscellaneous shoulder syndromes. I've already talked in other modules about frozen shoulder or adhesive capsulitis, rotator cuff tendinitis, rotator cuff tear, shoulder impingement syndrome, shoulder labral tear. This is a module that's picking up some of these other diagnoses that you'll see with the shoulder, understanding that some of these other diagnoses are often part of the more specific syndromes we've talked about. This module will include bicipital tenosynovitis, a complicated term for inflammation of the biceps tendon sheath. The long head of the biceps tendon passes through the shoulder joint, and there can be an inflammation of that tendon sheath. AC joint injury, the injury to the acromioclavicular joint. Sometimes that's called a shoulder separation if there's actually mechanical disruption of the ligaments of the AC joint. Advanced shoulder arthritis, which you'll often see in the elderly and can be confused with other shoulder syndromes. And shoulder instability, which you may see, for example, in the throwing athlete, sometimes associated with labral tears. A number of these patients will not fall neatly into the common syndrome, so it's important to keep these other miscellaneous diagnoses in mind. And a key thing will be, again, to focus on the history and the physical exam in order to have a reasonable idea of what might be happening with your patient before you leave the exam room. When we get in the exam room, I'll demonstrate these in more detail. This is for miscellaneous shoulder syndromes we haven't covered elsewhere. And the ones I'm going to highlight today are bicipital tenosynovitis. Let's put that in English. The long head of the biceps tendon goes through the shoulder joint and has a groove here. And that can get inflamed, right? It's a little bit covered there, but there's the long head of the biceps tendon shown here. That often goes with an impingement syndrome, but there's some specific findings. Another one can be the AC joint, acromioclavicular or AC joint. Sometimes acute injuries, such as football injuries, there's actually a separation and an elevation of the clavicle as these various ligaments can get injured. And then also advanced shoulder arthritis is one that we see, and also shoulder instability, which I touched on a bit with labral tears. Physical exam findings, pretty similar to what else we've looked at for the shoulder. I'll assume you've screened the neck and you've done some basic shoulder range of motion. But for example, for bicipital tenosynovitis, at least with a thinner patient, such as with Jennifer here, you can even just palpate the long head of the biceps tendon. Patients often have a focal tenderness there. AC joint is, you can just feel it just between the clavicle and the acromion. And it's often focally tender. When we bring the patient into crossed adduction, that's often a very specific maneuver for aggravating AC joint pain, which often is, there's an arthritis there that might get lit up from an injury. The AC joint, again, if I were on the patient, I'd be palpating between the clavicle, which is slightly raised, and the acromion, which is slightly lower. Shoulder instability, I've talked about that for labral tear already, looking at the apprehension test. So these are various shoulder syndromes that can also occur. Sometimes they're in the context of other common shoulder problems, like shoulder impingement can come from AC joint arthritis, in addition to what we see here with this subacromial space getting pinched. Also, we note, for example, that shoulder arthritis, glenohumeral arthritis, can be confused sometimes with a frozen shoulder. But with glenohumeral arthritis, you really clinch it by age group and imaging, but it's good to at least have some knowledge in the exam room. Any kind of motion will cause pain for the shoulder. So it's in your differential diagnosis with frozen shoulder. And then there's so-called zebras. I won't get into them in detail, but there's something called Parsonage-Turner syndrome, which is a brachial neuritis, where you get generalized shoulder pain followed by neurologic weakness. You can get referred pain from gallbladder disease or pancreatitis going to the shoulder. So keep those way in the back of your mind just in case patients are not really lining up diagnostically with what you might expect.